Idelalisib is a very, very active drug in such a wide variety of malignancies. So in order to make a 15-minute presentation that was somewhat bearable, I've tried to break it down by just looking at a number of studies. I'm going to present the studies and then the data last. So I apologize if this is somewhat difficult to follow, but I did my best. The studies I'm going to be presenting, you can actually see here, pretty much all from the last ASH. What's important is the Spurgeon data and the Benson data are actually final analyses, and then Gopal and Leonard are sort of ongoing. And what these are focusing on is these are the first, this one study, and Dr. Spurgeon looked at the mantle cell patients individually, is the phase 2 study of idelalisib in indolent NHL. Well, these are the indolent NHL patients from the phase 2 study. And Dr. Gopal looked at patients who were refractory to rituximab and an alkylator agent, and Dr. Leonard looked at combination data for idelalisib with ofatumumab, rituximab, and bendamustine. So I'm going to skip through this slide and this slide because we've certainly talked about it enough today. Just important to remember that the one thing I'd like to add is the fact that we're getting such great responses from agents like idelalisib and ibrutinib, I just think really further supports the whole idea of the microenvironment and its role in CLL, as these really are all basically it's the surface receptors that are driving our malignancies. So looking at what's called the 10102 study, which was a phase 1b dose-ranging study, and what I'm really going to focus on here is just the phase 2 component, but just so that everyone understands, patients were treated at 50 milligrams to 350 milligrams BID with continuous oral dosing. There is actually a difference in progression-free survival when you look at the patients who were treated at doses 100 milligrams and less compared to 150 milligrams and greater in the CLL patients. We don't have those data for the non-CLL patients, but I'm going to focus on just the patients who were treated 150 milligrams BID and greater, or rather 150 milligrams BID, which everyone was eventually put on very quickly. So the primary endpoint here was safety, but we were able to look at efficacy in this trial. Now, patients after 48 weeks were moved on to an extension study where they just continued their idelalisib. Just going over patient characteristics, what I really want to focus on here is that this was a very heavily treated patient population with 4 prior therapies. I'd also like to focus on since we're talking about not CLL, and every once in a while I'm going to have to remind myself not to slip and say CLL, but I want to point out that the majority of these patients were follicular lymphoma patients. There were a few CLL patients who slipped in under the radar as small lymphocytic lymphoma patients, but the vast majority were follicular lymphoma, and quite a few of these patients had bulky lymphadenopathy. So then the other thing that I want to draw attention to is the patient disposition, because I think this really is going to tell us what we need to do going forward with therapy with idelalisib and also what we can expect for our patients. So overall, remember, the completed study was 48 weeks long. So we had 19 patients, or 30%, complete the study, and out of these 19, eventually 18 or 95% discontinued while on the extension study. There still is 1 patient ongoing. The most common reason for discontinuation was disease progression. The second, of course, was adverse events, and the 2 of these really represent almost all of the causes of people coming off study. The median duration of treatment was 10.6 months. And now I'm going to move to the next study. And this is where things get choppy, and I apologize. But we'll go to those responses afterwards, and I thought it would just be an easier way to look at it. The second study is the 10109 study, and this study, once again, 150 milligrams BID in Rituxan and alkylator refractory indolent NHL. All right, and the primary endpoint, of course, was overall response rate here. And just to reemphasize that the key eligibility for this trial was actually being refractory to Rituxan or alkylator agent as defined by a response lasting less than 6 months or not having a response at all. So once again, this was also a heavily treated patient population with a median number of prior regimens being 4, with 100% of patients, we did it right this time, with 100% of our patients actually meeting the eligibility criteria and being refractory to alkylators and Rituxan. And here, looking specifically at the last regimen, and you can see that a lot of the patients went on to aggressive chemotherapy regimens, to CHOP and, of course, bendamustine, with 79% being refractory to greater than or equal to 2 regimens, and 90% being refractory to the last regimen. So this is a very refractory patient population. And then looking at the disposition of these patients, 68% discontinued treatment, 32% due to disease progression, 20% due to adverse events. Median time on treatment for this population was 6.6 months, with a mean of 8.1. And the final study, which is a little bit messier, is looking at idelalisib in combination with either Rituxan, bendamustine, or bendamustine plus rituximab. And here you could see the dosing schedule using bendamustine at 90 milligrams per meter squared and Rituxan at 375 per meter squared monthly, every 28 days for 6 cycles with the bendamustine, or just weekly times 8 if it was as a single agent. And then once again, patients continued on the extension study. Once again here, you could see that the key eligibility, once again, all the different types of indolent lymphomas. Prior therapy was actually just greater than or equal to 1 prior therapy. Looking at disposition here, 46% of patients completed the 48 weeks, 44 enrolled in the extension study, 54% discontinued, 15 of these to AEs, 11 to disease progression. On the extension study, 28 patients, or 35%, are still on treatment, with 3 additional patients having disease progression, 1 AE, and 1 death. I'm not exactly sure what the investigator request was, though. So the median duration of dosing here was 11 months. Now, with all that out of the way, let's talk about response rates. Because I think, by and large, the key information from those prior slides really relate to the fact that this was a very refractory population. And what I'd like to point out is that the 1102 patients weren't the Rituxan alkylator refractory patients by trial eligibility, but I think in practice they were that as well. So a lot of these data, I think, can be combined, but of course I've left them separate. So the overall response rate in the 10102 study was a 48% response rate. You can see here 43% response rate at 150 milligrams less than 150 milligrams BID compared to 58%. But what I want to emphasize is that the data that I found most impressive was the progression-free survival data for the CLL patients when you broke it down by less than 150 versus 150 milligrams and greater. CR rates, you can see, were quite low, but the PR rates were very significant. And looking at the waterfall plot, which I think actually have a lot of pertinence to our patients because they really do seem to suggest that patients are getting benefit even if they don't meet our artificial criteria, you can see that the vast majority of patients have a very nice reduction in, not vast majority, but the vast majority of patients have some reduction in lymphadenopathy, with almost half having a sufficient amount to qualify as a partial response. You can also see here that there were a significant number of patients that were primarily refractory. And this, by the way, includes several Waldenstrom's patients who responses there included the minor response category. Looking at progression-free survival for the population overall, it was 7.6 months was the median. And then looking at the mantle cell patients who were culled from the earlier data, we have an overall response rate of 40% in the mantle cell patients with 7.5 CRs and 32.5 partial responses. Once again, you can see a significant difference here, though, in overall response rate based upon the doses received. Once again, the waterfall plot showing that a large number of patients had some reduction in lymphadenopathy. And here you can see the progression-free survival was 3.7 months in this patient population, with a duration of response of 2.7 months. And then looking at the 10109 data, this was the Rituxan refractory and alkylator refractory patient population. Remember that these patients had also the same median number of prior therapies, which was 4. Overall response rate, 57%, 6% PRs, and 50% partial responses, with the one minor response being a Waldenstrom's patient. Time to response, once again, very quick, 1.9 months, and we saw some slides from John earlier that spoke to that more specifically. Looking at the forest plot, you can see here that the response actually was seen regardless of histology. And looking at the waterfall plot, you can see here again that the vast majority of patients had some reduction in lymphadenopathy, with only about half achieving sufficient to meet the criteria. And then the progression-free survival for this patient population was 11 months, significantly different from the earlier study. Now, looking at the 10107 study, here we have our individual responses with idelalisib. So we have a 72% overall response rate for Rituxan plus idelalisib, 85% for bendamustine plus idelalisib, and 71% for bendamustine Rituxan plus idelalisib. Of course, these error bars all overlap, so I'm not going to make too much of this difference here between these two. Overall, 78% response rate with 26% CRs. Looking at the progression-free survival for the population overall, you can see that the median is not reached, with a 62.5% progression-free survival at 24 months. Now, splitting it down by individual treatment regimens, you can see here that they're almost all superimposable, which I thought was really quite interesting compared to what we might have expected, with Rituxan being certainly less likely to be effective than a bendamustine or a bendamustine-Rituxan combination. That's the response. And then I just want to spend a little bit of time on adverse events. I'm not going to go through the adverse events for all the trials. What I did here is just pull the adverse events for the 10102 study, and I just want to call out the diarrhea question, which was spoken to earlier, as well as the pneumonia issue with the question of pneumonitis occurring in some of these patients as well. The rest of these adverse events were almost all completely grades 1 and 2, and were very rarely, except for the diarrhea and the pneumonitis, responsible or associated with discontinuation of the drug. The one other issue, of course, is the ALT and AST elevations, which we've come to learn a lot about subsequently, and I'll talk about that in the next slide. Actually, what I did here is actually pull together the adverse events from the 07 study to look at the adverse events from the 02 study. And so here would have the ultimate question is whether or not the combination of idelalisib plus chemotherapy is going to have an impact on our adverse events. Of course, it's hard to know what the baseline adverse events might be with regard to just the chemotherapy alone. So here we're comparing idelalisib alone to idelalisib plus chemotherapy, trying to ask whether or not the idelalisib makes the chemotherapy worse, and of course that's a question that we cannot answer with these data. But just, looking out here with the pyrexia being now the most common adverse event, here you can see diarrhea occurring in about 35% of patients, and 8% having the grade 3, which actually was lower than what we saw with the single agent data. And then just looking at the transaminitis elevation, occurs early, usually by week 8. Latest was seen at week 16. It's asymptomatic and reversible, and I think this is really important. So these patients aren't presenting with symptoms. And so if your patient does have symptoms, I think it's important to look for another cause of the transaminitis. Grade 3 management included holding the drug and rechallenging. The 75% of the patients tolerated the rechallenge. There were actually quite a few patients who had less than or equal to grade 2 elevations who just continued dosing. And in all of those patients, the transaminitis resolved. So, of course, one of the interesting questions would be what would happen with the grade 3 transaminitis, and I think that's going to be a question we're never going to attempt to answer, though. And there was no grade 3 bilirubin elevation and no liver failure. So, of course, if you see any signs of worsening liver function or of a hyperbilirubinemia, it's likely not to be the idelalisib.